Good afternoon and welcome to our medical lecture series. I am Dr. Galit Hakim, Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Gladys Giron. Her presentation is titled Breast Diseases. Dr. Gladys Giron is a breast surgical oncologist at Baptist Health Miami Cancer Institute. She completed 2 fellowships in breast surgery and currently serves as chair of the Breast Leadership Program at the Breast Center at Miami Health Miami Cancer Institute. Dr. Giron earned her medical degree from the University of Miami Miller School of Medicine and completed her surgical residency training at the University of Miami Jackson Memorial Hospital. She completed a clinical and research breast surgery fellowship at Memorial Sloan Kettering Cancer Center in New York and a breast surgery fellowship at Columbia University College of Physicians and Surgeons at St. Luke's Roosevelt and Beth Israel Medical Center, also in New York City. Before joining Baptist Health Miami Cancer Institute, Dr. Giron was a medical director at the Taylor Breast Health Center at Jackson Memorial Hospital. She has published numerous research articles and spoken in multiple congresses and seminars around the globe. In medical journals, she has published numerous articles and is an assistant clinical professor of surgery at Florida International University, Harvard Wardine College of Medicine. Please let's give a warm welcome to Dr. Gladys Giron. Dr. Gladys Giron, welcome. Thank you so much for accepting our invitation. The floor is yours.
Thank you very much to everyone who is joining us today. We really appreciate that you are here, and I hope that this presentation will be very informative to you, and more importantly, that it will be a foundation in terms of understanding breast diseases that you can take with you forever in your practice. Breast diseases are very common, are a big part of our follow-up. So I'd like to go ahead and get started. Dr. Hakim, everything is good? You can see my screen?
So far, so good.
Okay, perfect. Okay, so we're going to go ahead and get started, and then write down your questions. At the end of the presentation, we'll have some time to go over any questions that you may have. Okay, so the CDC reports an estimated 1 billion office-based physician visits in the United States in 2019, and of those, 50% were females. Of those female patients, approximately 3%, which still is a very large number, were having breast symptoms. Now, it's very important to understand that the prevalence of breast cancer in women who have breast-related symptoms, pain, itching, all the sorts of things that they can come up with, only 10% of these patients will actually have a diagnosis of breast cancer. So there are a lot of visits that will not result in the diagnosis of a carcinoma, but obviously the important thing is to not miss a breast cancer.
Dr.
Also, which
Giron,
is something that is very important, is to understand that patients who do see their primary care physicians are more likely to undergo cancer screening and therefore less likely to have a delay in their diagnosis. So what you do, whether you're a family practitioner, you're an internist, a gynecologist, will have a big impact on patients' survivability if they do have a cancer.
Dr. Giron, I'm sorry to
Yes.
interrupt or interject
Yeah.
rather. Could you click again on your presentation? It went away.
Oh, no. Okay.
I
Hold
didn't
on.
want
Let
to
me
interrupt
see.
you.
No, no, that's okay. I'm just trying to. Oh, is that the screen? Can you see it at all?
We can see you, but not the presentation just yet.
Oh, goodness.
It's okay.
Okay.
Take your time.
Bear with me because my screen, it's not letting me do anything here. Hold on. Let's try this again. Give me one moment. I do apologize.
No, please don't be.
Forgive me. Let's see. Let's try this, and then we'll hit presentation and see if you can see it now.
Perfect.
How's
You
that?
just,
Okay.
yes, it's right there. So make it exactly. Thank you so much,
Okay, so
doctor. I apologize for the interruption.
Oh no, I apologize for the little issue there. So
Not
hopefully
an
we're
issue.
okay. Well, this was the first slide we just talked about, so we can move on to the next one. When we're looking at breast diseases, we want to become familiar with the breast diseases so that we can lead to a timely diagnosis and a better prognosis. So what can we see? We can see benign things. We can see breast pain. Patients can come in with nipple discharge, with breast masses. We see mastitis. We see high-risk categories, which is really beyond the scope of this presentation, but just to touch on it, we can see patients with a diagnosis of atypical ductal and lobular hyperplasia, lobular carcinoma in situ of classic type, patients who come in with a significant family history or pathogenic genetic mutations. And then, of course, we look at malignancy. So in situ and invasive disease, we can see patients with malignant Phyllodes tumors and others like lymphoma, metastatic lesions, etc. So we're going to start with the most common breast complaints that a patient will present to you with. They can present with breast pain, nipple discharge, a palpable mass, and mastitis. So in terms of breast pain or mastalgia, it's the most common breast symptoms that patients will present with when they go to the primary care physician, gynecologist, or a breast surgeon or a general surgeon. And this may be partly due to increased public awareness. So at least here in our area, we are heading into October, which is Breast Cancer Awareness Month, where everything turns pink. And every time you turn around, there's a commercial, there's a public service announcement, there's somebody speaking to you who has breast cancer, and they become very concerned. And so anything that the patient feels immediately in their mind, they're thinking they have breast cancer. So breast pain, although rarely associated with breast cancer as the only symptom, leads to a lot of visits. We have cyclical breast pain, which is going to typically be bilateral, most severe before menses and diffuse, and then non-cyclical, which we can see in patients who are in their ages of 40 to 50. That can be unilateral and it can be localized as well. So those are the two really broad categories that we look at. In terms of the workup, obviously, we want to make sure that we do a clinical breast examination and that their breast imaging, if they're due for screening, depending on their age, if everything else is normal. Only if the breast pain is going to affect their quality of life do we then ask them to do other things. One of the things that we ask them to do is to keep a breast pain journal. You can find many versions of this online that the patient can upload. There are apps. They can just write it down on a piece of paper or their calendar. But basically, we want them to look through the month and then give us an idea of when the pain is worse and see if we can sort of find a relationship with certain activities. For example, I had a patient one time who was having horrible breast pain, and she didn't really think about what was what because she was worried it was breast cancer and figured that it was only happening when she was walking her neighbor's dog, who was a very large dog. So we were able to find a connection. So the breast pain journal is sometimes helpful. And then management, typically what we're going to do is give the patient reassurance. We really don't need to do much, just like it comes on spontaneously, it's going to resolve. Danazol is the only FDA-approved medication. We try not to use this. Obviously, there are more side effects than are going to be helpful. And then we also know that there are wives' tales or urban legends like caffeine avoidance and vitamin E. They have not been shown to be effective in any studies, but we do know that evening primrose oil can be effective. So that's one of the things that we recommend for our patients who are having persistent breast pain. Nipple discharge. So nipple discharge, I like this diagram because it kind of gives us an idea of the different types of nipple discharge that we are going to see, but it is a very common complaint that patients will present with. So if we look at this, most of the time, nipple discharge is going to be benign. Okay, so you can see the picture in the upper corner where we have a patient that presents with serous discharge. 2 to 3% of patients with breast cancer will present with nipple discharge. So you would think it would be a larger number. But the importance here is for you as students, as primary care physicians, as gynecologists, differentiate between what is physiologic and what is pathologic. And obviously, when something is accompanied by other symptoms like a mass, changes in skin, all of these things come together, abnormal mammogram or ultrasound, those other symptoms or signs will take precedence over the nipple discharge. Okay, so we need to make sure that we're not ignoring everything else and looking at the nipple discharge and establish that this is the presenting problem. Physiologic nipple discharge. It's a black and white picture, but it's a good representation of what we see when we have physiologic nipple discharge. You see multiple ducts are involved and that they're different colors. Milky, we have here greenish black, we have clear, here a little bit thick. So we only see it when the nipple is squeezed or compressed, multiple ducts. It's frequently bilateral. The discharge can be thick. It can be yellow, dark green. If you're not sure what color it is, because dark green can look bloody or black, touch it to a gauze, and then you'll notice that it's green, and then you know it's physiologic. In up to 20% of patients, we can actually elicit nipple discharge if we try. So it's a common complaint. Patients that have had babies and breastfed will often continue to check and see if they still have discharge, if they still produce milk. What do? We tell them don't squeeze. All right, so physiologic nipple discharge, just don't squeeze. It's nothing to worry about. Okay, multiple ducts, different colors, we're good. Duct ectasia, you'll see the picture where you can see the nipple almost has like a little opening, almost like a piggy bank or a cleft in the middle. This is not nipple retraction. It's something that is related to duct ectasia, common in older women. The nipple retraction or that indentation comes from dilated ducts that will become fibrosed and will pull in the center. The nipple discharge is usually going to be pasty, thick. You can see the picture here. Sometimes there can be bloody. And it can be a nuisance. So when it does become a nuisance for the patient, sometimes we have to make an incision around the areola and just disconnect those terminal ducts. The only side effect of doing that is that the patient will not be able to breastfeed, right? But this is typically going to be in older patients, and it gets rid of that bothersome discharge that they're experiencing. Pathologic discharge. So you see a picture here of bloody nipple discharge. This is now going to be spontaneous. Okay, so they notice it on their bra, in their pajamas, or taking a shower. It can be bloody, can be serous, can be clear. It's usually going to be unilateral, involve one duct. So when you examine the patient, it's going to come out of one duct. Cytology for me is not helpful. I don't think it makes much of a difference. If you get back abnormal cytology, it doesn't give you any guidance in terms of where this is coming from or what to do. So I don't do it. And then this is a correct time to refer the patient to the breast surgeon. You will see that the most common cause is going to be an intraductal papilloma, and you'll have a picture on the bottom of a pathologic slide of a papilloma where you can clearly see the polyp, if you will, arising from the wall of the duct. And sometimes for this, the patient will require a terminal duct excision, or sometimes we can actually localize if there are imaging findings and just remove the area that has the papilloma in it. And last, galactorrhea, I won't spend too much time on this. This is mostly a problem for the neurologist. Okay, so we know that we can have microadenomas where you would have hyperprolactinemia, and galactorrhea is going to be bilateral and very copious discharge. Okay, having just milky discharge, a couple of drops does not qualify as galactorrhea. So we don't need to do anything surgically from our standpoint. Now we're going to go to breast masses. What kind of breast masses do we see? The differential diagnosis is going to include a cyst, fibroadenomas. We can sometimes see something called fat necrosis, and then also malignancy. And you'll see some pictures here that I've included of what the masses will look like on mammography, on ultrasound, and on the bottom, we have examples of these big coarse calcifications, and these are consistent with fat necrosis, usually the result of trauma or breast reduction, breast surgery, and radiation. So these are common findings as well. In terms of cysts, they're less common in postmenopausal patients. So if you have an 85-year-old presenting with a cyst, you may have more concern than if we see it in the typical younger premenopausal patient. These will present as a dominant mass. It can be painful. They can be palpable. They're well-defined, round or oval, anechoic with thin walls and through transmission, very characteristic appearance on an ultrasound. The treatment, we're going to aspirate. Under ultrasound guidance is better if the cyst is dominant or symptomatic. If they're not symptomatic and they have multiple cysts, we do not need to aspirate them. But if you do it under ultrasound guidance, as you see the picture, you're less likely to leave behind pockets that will then reaccumulate and cause the patient's symptoms again. So once the patient has had an aspiration, it is helpful, if possible, to examine them again in 1 to 2 months and make sure that they don't reaccumulate. We are only concerned if, when we go to aspirate, instead of seeing that nice serous fluid that you see in the picture, we get bloody aspirate, or if after 3 aspirations, it will recur. Other than that, we don't really operate on patients with cysts. It is very rare to operate on a patient with cysts for us. And then we also will find sometimes a solid component of the wall of the cyst. The radiologist will usually biopsy this and make sure that we don't have anything atypical or malignant that would require excision as well. Solid lesions. So we have benign solid lesions. These are fibroepithelial lesions and the fat necrosis I alluded to before. And then, of course, within the category of malignant, the most common is going to be the adenocarcinoma or your breast cancer. We can see malignant phyllodes tumors, primary breast lymphomas, and then metastatic lesions. So fibroepithelial lesions, this is very common. I can say to you that all of you will encounter patients with these lesions. And again, you'll see on the mammogram that I've included here, multiple areas of fibroadenoma. So fibroepithelial lesions are a family. They present as a palpable mass. They will look and feel the same. Each of them, the only way to tell the difference between the different categories is to actually have a tissue sample. And even with the tissue sample, sometimes the only way to differentiate is to take out the entire lesion because the diagnosis relies on how many high-power fields have mitosis that the pathologist is observing. We have fibroadenomas, cellular fibroadenomas, and benign phyllodes tumors. They are the most common masses in women under the age of 25. They can be single, they can be multiple, they can be synchronous, they can be metachronous. They will regress with menopause, and that's what this mammogram is showing you. This is a lady who is already postmenopausal, and she has all these calcifications that literally look like somebody threw a piece of popcorn on it, and so these are called popcorn calcifications. It is a favorite test question. Fibroadenomas can also achieve very large sizes in teens. We call these juvenile or giant fibroadenomas. So the patients can present with pain, rapid enlargement of the breast, and even nipple displacement. And everybody is concerned this patient must have a cancer. Just keep in mind that giant fibroadenomas are seen in teens. And you have to be careful also if they're in a central location that you not operate on the patient and actually remove the breast bud. Sometimes the breast bud can become tender and palpable, and if you do that, then you've caused surgical amastia. So know the difference. Here is an example of a fibroadenoma in terms of what it looked like on ultrasound, what it looked like grossly, and what it looks like under the microscope. For us, we do an ultrasound-guided core biopsy if it's a new single solid lesion. If the core biopsy shows increased stromal cellularity, then we worry about cellular fibroadenoma or phyllodes tumors that grow quickly. If it's just a fibroadenoma, we will remove it if it's greater than 2 centimeters, although it depends on the patient. If they're symptomatic, so it's in the upper inner quadrant, every time they put on their clothing, they can see it because they're very thin or it's painful. Sometimes they're next to a neurovascular bundle. If on ultrasound, we notice that there's a significant increase in size or a change in contour, these are reasons to remove them, but we don't always need to remove them. Mastitis, so swelling and redness of the breast. It can be painful, associated with fever, chills. It's common when patients are breastfeeding. We treat them with antibiotics, supportive bra, compresses. If symptoms worsen, we may need to have the patient pump and then refer to an incision and drainage. In non-lactational mastitis. So this is an example of a lactational mastitis. So you can see the patient was basically about to ulcerate and drain the pus from that area. She was breastfeeding. But for me, the most important take-home message is if the patient is not lactating and they present with something that looks like a mastitis, be certain that you do not have a diagnosis of inflammatory breast cancer. So that is very important. We see a delay in diagnosis when they continue to see healthcare providers and they are given antibiotics with the thought process it's a mastitis, but it's not. So the next page will show you here. This is a patient of mine who presented with an inflammatory breast cancer. You can see the redness, right? So it's a rare type of breast cancer, about 2 to 4% of all breast cancer cases in the United States. It is a locally advanced cancer. The dermal lymphatic invasion by the tumor cells is what causes the thickening and the redness. It is a clinical diagnosis. You will never have a biopsy result from the pathologist that tells you inflammatory breast cancer. The definition is you are going to see redness, the peau d'orange, of a third or more of the breast. So 30% or more of the breast with this, and we have a diagnosis of inflammatory breast cancer. Doing a punch biopsy is not always diagnostic. It doesn't always show us the tumor cells and the dermal lymphatics, so you don't really need to do that. Clinical. Rapid onset. Patient comes in and says, this just very quickly came on. Don't miss this because these tumors are very aggressive and we want to get them to systemic treatment as soon as possible. Breast cancer. What's the statistic that we hear is 1 in 8 women will develop breast cancer. The main risk factors are you are a female, and you are over the age of 40. In men, it's going to be 1 in about 700 men will develop breast cancer. Also very important to not ignore that. There is definitely increased awareness of men with the diagnosis of breast cancer. So we are seeing them at earlier stages than we used to. Make sure that if a patient comes to you and there's a mass in a male, that it's not gynecomastia. Gynecomastia would be right behind the nipple areola, a nice disc type process, which all men will have during puberty. It will then resolve, and we can see it associated with steroid use or medications. But anything that's eccentric, nipple retraction, nipple discharge, skin changes, could be a breast cancer in a male. And then also important, of course, that as you get older, your risk of breast cancer increases. Most breast cancers are found in women who are in their 50s and 60s and older ages, although we have seen somewhat of an increase in younger patients, not to the same degree that we are seeing in colorectal cancers. So here's an example of what the pathologist will see under the microscope that basically gives us a continuum of how we get to the diagnosis of breast cancer. So we start with a normal duct, right? We have our lining, the myoepithelium, then we can have ductal hyperplasias, which we don't do anything about, but now we get to the next category, which is the high-risk atypical hyperplasias, can occur in the lobules, less significant for us, we don't operate them. Ductal, we do operate on because we can upgrade in about 20% of patients. And then we get to ductal carcinoma in situ. And then once the membrane of the duct has been invaded and the tissue infiltrated, we now have a diagnosis of invasive ductal carcinoma. We also have lobular carcinoma in situ of classic type, which falls under a high-risk lesion. This is something that we no longer as a standard. If things are concordant, we do not operate on patients with lobular carcinoma in situ of classic type. Most women who come in with a family history of breast cancer will not have positive genetic testing. Most of our patients that come in with the breast cancer are not going to have positive genetic testing. So we will see a mutation in about 5 to 10% of our patients. A pathogenic mutation is going to be more likely with a strong family history. That means you have a family history, you have ovarian, pancreatic, prostate, and breast cancer, bilateral breast cancer. More important if you have first-degree relatives. The greater the number of family members, the greater the chances that you may have a mutation, although we don't all know our family histories. And so sometimes when we expect something's going to be positive, it isn't. And when we expect that we're not going to have a positive result, we find out that there is indeed a mutation in the patient. Our current recommendations right now, if you have the resources available, are to test any patient who's diagnosed with a breast cancer. It allows us to give the patient recommendations for their own care and also to gather information so that we can then discover new mutations and be able to act in preventive ways. Here, this is not my slide, but it's very nicely put together in terms of what are the main mutations that we see. Clearly, the ones that we know the most about are going to be BRCA1 and BRCA2, but you see these other mutations that we will also test for. And typically what we do is we actually will look at a panel of up to 77 different genes. So we're not just looking at breast, we're looking at other syndromes, if our patients have a family history of colorectal cancer. So we try to be as comprehensive as we can when we're doing that genetic testing. And just remember that most of the time the result is indeed negative. Okay, I put this here. I don't expect you to read it, and I'm not going to read it either because it's very long, it's very wordy, but the American Cancer Society will put out its screening guidelines, which typically the family practitioners will then look to and follow. For us as breast surgeons within our societies, within our professional organizations, and within our practice, what we will say is that a patient should start their mammographic screening at age 40 and yearly thereafter, as long as they are in good health. So we can have a 95-year-old patient who is very active, goes bowling with her friends every day and has a wonderful life. And if anything happens with a breast cancer diagnosis, she is going to accept treatment. And then have a patient who's in their mid-50s who's very ill, end-stage congestive heart failure. And if she has a breast cancer diagnosis, will not be able to receive treatment. So as long as you are functional and you are doing well, if we diagnose a breast cancer, you will accept treatment. You can continue to have your mammograms, but our start age is 40 and then yearly thereafter. There's an example of a screening mammogram on the lower part of my presentation screen. And basically a screening mammogram is going to consist of 2 views on each breast, If the patient happens to have implants, whether they be cosmetic or part of reconstruction, they will have 4 views per breast, views with the implant in place and then displaced as well. Okay. So what is a screening study? A screening study is going to be done on a patient who is asymptomatic, but you're looking for a disease that is prevalent enough in the population that if you find it, you can prevent a later stage of diagnosis. Okay. That's a screening study. Now, if the patient is presenting with other symptoms, then we're looking at diagnostic studies. So patients can come in with a breast cancer as a palpable mass. This is typically going to be painless in direct opposition to a painful mass, which is most likely going to be a cyst. Masses can be detected by the patient or on clinical breast examination. We can also see breast cancer patients presenting with skin changes, like the slide that I showed you not long ago, where you have erythema. You have thickening of the skin. You can have retraction of the skin, of the nipple, of the areola. They can have bloody, clear, or serous nipple discharge and nipple inversion as well. So these are all symptoms that we will see in patients. I have an example here of breast cancers and how they present on mammogram. So on the 2 views, the MLO or medial lateral oblique, in that view, when we do these studies, we will see that the top in an MLO is going to be superior. The bottom in the MLO is inferior. And then the next view, which is CC, off on the top, that's going to be lateral, and down toward the middle is going to be medial. So we are able to reproduce a 3D image, if you will, with a 2-dimensional image. And then we have the tumor on ultrasound as a solid irregular lesion, and then a lesion that you can see on MRI that is enhancing, that is irregular as well. So these are the primary modalities that we use. We will do only tomosynthesis mammography on our patients, and a newer technology that we are using is contrast enhanced mammography. The utility of that study is that if a patient has severe claustrophobia, a lot of anxiety, and they can't get into the MRI machine, or they have back problems and they can't lie flat, contrast enhanced mammography may help us to get that different view of the breast tissue. So that is a newer technology that we are employing at this time. So the standard of care for a breast cancer patient is to proceed with a core biopsy, a needle biopsy. Without image guidance, you can do it if the patient's coming in with a large advanced disease. Otherwise, with image guidance, whether it be mammogram, ultrasound, or MRI, is the best way to proceed. And then we will place markers to identify the area that has been biopsied. And the markers can be metallic, they can be magnetic, they can be found through radar detection, or even radioactive. And we'll see examples of that in my next slide. If resources are not available and you cannot do a needle biopsy, then you may have to do what we call an incisional biopsy for a bigger tumor, or an excisional biopsy for diagnosis. But for the most part, we like to establish that diagnosis as a standard of care with the needle biopsy first. Why? Some patients are going to be candidates for preoperative systemic therapy. They're going to need chemotherapy first, not surgery first. So this helps us very much in guiding what's going to be the sequence of events in terms of the multidisciplinary care of our breast cancer patients. I'm going to show you on the next slide different image-guided biopsies. So ultrasound is always the easiest for the patient and for the radiologist, obviously. In terms of positioning, very comfortable for the patient. You can see the image with the needle going through the mass. And when the needle goes through the mass, you see the reverberations and what we call the bayonet sign. And then we have a stereotactic biopsy. So in the stereotactic biopsy, we have a finding that is really only seen on mammography or on tomosynthesis. And now the patient can either be lying flat, which is the more typical way of doing a stereotactic biopsy, or sitting up as well. And in essence, you're going to rely on the computer. It's computer-aided detection to find the area that needs to be targeted. The area is numbed, an incision is made, and the core biopsy will then remove 5 to 6 cores in the area of concern. And in all of these, a marker will be placed. So the next set of pictures are the markers. We have 2 examples. We have here a rod, and then we have another one that we call a top hat. They're very small. We also call them clips. They're not clips. They don't grab anything. They're not staples. They don't do anything. They're just deposited like X on a treasure map. It just shows you the location. So if you do a biopsy and you get back a cancer, you want to know where you biopsied. That's where it is. So that's what the clip helps us with. You don't feel these and you don't see these. So when we operate on the patients, we have different ways of doing things. One of the technologies that we use, which is going to be here on the lower right-hand corner, is going to be radar detection, okay, where we will, in essence, place a reflector. The reflector, you can see there, looks like it almost has two antennas. It's very small, like the size of these markers. And there will be radio frequency waves that are detected with the machine. And so when we have a mass that is not palpable, we will listen for a noise and be able to remove a non-palpable mass. We also will look at lymph nodes in terms of technology, right? So our breast cancer patients are going to have sentinel lymph node biopsies. You will hear the sentinel lymph node described as the first draining lymph node. That's actually not necessarily accurate. What happens is we have lymphatic vessels throughout the breast. Their function is to serve as filters. So for example, a patient has a tattoo. When a patient has a tattoo, don't be surprised if you operate on them and you find a blue-black lymph node in their axilla. It doesn't mean there's a melanoma. Usually it's the tattoo ink because that's the function of the lymph nodes, is to filter what's there. So if there's a breast cancer, the cells can either go hematogenously and spread, or they can get into that lymphatic vessel. And then the lymph nodes that are sitting in the tail of the breast and the axilla will absorb those cancer cells. The lymph nodes whose function it is to absorb those cancer cells are called the sentinel nodes. Okay, a sentinel is a guard. It's the guard who would basically watch a fortress. So the sentinel nodes are the guards of the axilla. They're going to be the first ones to catch things. The analogy that I like to use is this. You have a baseball team. I like baseball. I'm from New York. I'm from Queens. So I'm a Mets fan. So baseball works for me. Okay. So you have a baseball team. The batter is at bat. The catcher is the player who's principally charged with catching that ball, even though all the other players can come in and catch that ball. So your sentinel node is the catcher on your baseball team. It's not always one. On average, it's going to be two. It can be one or it can be many, depending on the patient. And it's not always the first one. So it's not location, it's function. How do we find them? Two ways. We can inject blue dye. There are different blue dyes that we can use. You can use methylene blue. You can use lymphozurin or isosulfan blue dye. That is injected either behind the nipple areola, around the tumor. But in essence, the blue dye will be taken up the way a cancer cell would, and we look for blue lymph nodes. Caution the patient that they will have blue-green urine and bowel movements for 24 to 48 hours so that they're not frightened when they see this. We can also inject what we call technetium sulfocolloid, okay, or a radioactive colloid, what we call a gamma injection. That's going to be injected in the same way in nuclear medicine. This out of your system within 24 hours. It's safe to be around. Pregnant doctors and surgeons and radiologists use it. And we have our probes. That probe will then, we use the Neil probe, but that probe will detect a high-pitched noise that is made by the radioactive colloid that has been taken up by the sentinel lymph node. So there's two ways that we can do that. If the patient has had chemotherapy and we see things can fibrose and scar down, we're going to use both of those. Sometimes it's up to surgeon preference whether you use one or the other, but after chemotherapy, we use both. So there are some other technologies for finding sentinel lymph nodes, but these are the standard or the gold standards. It's what we use in our practice. So breast cancer surgery. I am a breast surgeon. The majority of what we do is taking care of breast cancer patients, but I wanted you to learn about the benign things, because only by knowing what is benign are you able to say, okay, we're good, and then concentrate on not missing a breast cancer diagnosis. What are the different options for breast cancer surgery? So first is breast conservation, what we call a lumpectomy. Lumpectomy really should be reserved for cancer, for DCIS, for cancer, sometimes for atypical ductal hyperplasia. But you're removing the tumor and a margin of tissue around the borders. That margin is not large, but it allows the pathologist to see the ducts that are beyond the area that we have detected, to make sure that there aren't microscopic areas of disease that are not detectable on your imaging studies or on your physical exam. With lumpectomies, you can do it if the tumor is palpable. And then we already talked a little bit about this already, but with guidance, if they're not palpable. So we have wires. Okay, so basically we're going to shish kebab the area of the tumor with the wire that's placed by the radiologist. We have the reflectors, which I already showed you on the last slide, makes that clicking noise. And then there are also magnetic or radioactive seeds. We don't use those in our institution, but other institutions do. The radioactive seeds are not as popular for obvious reasons. So here are some examples. You see on the left-hand side of the screen, you can see the reflectors that we just looked at on the other slides. The circular areas are actually clips, radiologic clips that the patient had, but you can see that spiculated mass in the center, that's the cancer. And then the other ones are surgical clips, but that's a reflector or a radar localization. And then the others are examples of wire. So you can see the wire is placed by the radiologist and in essence goes through the tumor so that I know where to operate. And then here you have an example of what the lumpectomy specimen looks like after we take it out. You see the wire, the radiologic clip is right along the wire, so it doesn't show up too well on this x-ray, but that's how we do lumpectomies when we cannot palpate them. Lumpectomies can be performed through many different incisions. We can use curvilinear incisions. We can use radial incisions. If the patient has a larger breast, if they have ptosis, so the breast is already descended somewhat, then we can work with either ourselves or we can work together with our reconstructive surgical colleagues and do what we call an oncoplastic surgery. Onco for oncology, the breast cancer, and plastic, meaning that we're going to reduce or lift the breast. So it allows us to remove the tumor, a large margin of tissue. And at the end, the patient has the benefit. For example, if they were always thinking of a reduction, they have back pain, they have cervical back pain, a lot of intertrigo underneath the inframammary fold. So they were always thinking of doing this. There's an added benefit to the patient and also for the radiation oncologist. A larger breast is more pendulant and mobile. Giving radiation is not as uniform. If you have a smaller breast, your radiation is delivered in a more uniform fashion. So there are many advantages to doing an oncoplastic procedure. Okay. So you'll see on the bottom here that we can use the Wise pattern incision, which is really the reduction incision, right? You start with what looks like a keyhole, and at the end, it looks like an anchor. Mastectomies. So depends on the patient. Most of our patients are going to come in with the thought process of just do mastectomies. I want this over with. I don't ever want to think about this again. That's not true. Mastectomies are not always the best choice. Lumpectomy and radiation is going to give you results that are equivalent to a mastectomy. So we know in terms of your prognosis and survival, we can offer you these options sometimes. Depends on the location of the tumor, the size of the tumor in relation to the size of the breast, your genetic testing results. Is there more than one area of tumor? So sometimes mastectomy is appropriate, sometimes it is not. That's why you really need to be with experts, see people who are trained in breast surgery and are part of a multidisciplinary team. So we can do a total or simple mastectomy. That's going to be removal of the nipple and the areola. Part of the skin, most of it is spared, and the breast tissue. Then you can do a modified radical mastectomy. So this is for patients that have more advanced disease. They come in with lymph node disease already. This means you're going to do the same thing that you're doing with a total or a simple mastectomy, but it includes an axillary node dissection. So in those patients, you're not going to do a sentinel lymph node biopsy because when they came in, they already had cancer in their lymph nodes. That's the difference between a total or simple and a modified radical. Modified radical includes an axillary node dissection. Mastectomies, we perform them through many different incisions. So we can do a periareolar, we can do an ellipse, we can do what we call like a lollipop, we can do a radial incision. So there are many different options and we really fashion them depending on the anatomy of the patient, the location of the tumor. Are we doing reconstruction? Are we not doing reconstruction? Obviously, if we're not doing a reconstruction, we're not going to preserve the majority of the skin. Nipple-sparing mastectomies. Nipple-sparing mastectomies are newer, but have been part of our practice for many years now, probably more than 10 years. And in these cases, you cannot have a tumor right behind the nipple, right? So that's like our number one reason for not doing that. But basically, we're going to remove the breast tissue. The nipple areolar complex and the skin are going to remain. We have oncologic considerations. Remember, again, we can't do it with a central tumor, and also very large and advanced tumors, we're not going to do nipple sparing because the majority of the breast is going to be involved. Anatomic considerations. We're going to look at the ptosis of the breast. If the patient has a lot of ptosis and a large breast, the distance from the clavicle to the inframammary fold is very long. It's going to be difficult to maintain good blood supply to the skin envelope and to the nipple areola. So if the breast is ptotic or very large, we cannot do it. It's better for patients who have smaller breast. Also, if the patient smokes, not going to do nipple-sparing mastectomies. Why? Because they have microvascular disease. We can have them stop smoking If they really, really have for at least 2 weeks, sometimes we can pursue this, but we like a longer time frame. So smoking is really a contraindication to nipple-sparing mastectomy because the risk of necrosis is too high. And then we also use a lot of caution in patients who are diabetics. If they have uncontrolled diabetes, a lot of that microvascular disease, we're also going to avoid doing nipple-sparing mastectomies on these patients to avoid undue complications and delay in their care if they need systemic therapy afterward. For nipple-sparing mastectomies, we can use different incisions. The two most common that we use are going to be the top one, which is a radial incision off to the side, and the other one, which is called the invisible incision. It's going to be along the inframammary fold, so that'll come along the area where a bra band will be, so you won't really see that. We also use other types of incisions depending on the patient, so sometimes we get creative with our reconstructive surgeons. What's the reconstruction? We can use tissue expander or implant base. That's the most common. A tissue expander is a temporary implant. We put it in at the time of surgery, gets filled with saline, and then later it gets exchanged for an implant at another time. We can use autologous flap reconstruction. The most common is going to be our deep flap. We can also use sometimes a latissimus flap, but this does not give you enough volume, so that's typically done with an implant, and that it will also be commonly used in a patient who's already had lumpectomy radiation, has already had breast cancer. And then we can also use fat grafting. So the fat that's removed with liposuction can then, from the thigh or from the abdomen, can then be used usually in the upper poles because there's a bit of concavity after a reconstruction because the implants don't really fill that space. And so fat grafting also becomes part of the treatment in terms of reconstruction. And that's usually done at the second surgery by the reconstructive surgeon. What else happens? We're a multidisciplinary team. The surgeons are usually the first person to see the patient. We work with our reconstructive surgical colleagues. Our radiologists, pathologists work with us hand in hand, but then we hand it over. It's like a relay race. We have the baton, now we're going to give it to the medical oncologist. The medical oncologist is like the primary care physician for a patient with breast cancer. Chemotherapy, we can give it before surgery in patients with large tumors or a lot of disease in their lymph nodes. Post-operatively is more common. And then, of course, we have immune therapy. These are all talks in and of themselves. We could talk about this for at least another hour. Radiation therapy, that is given together with lumpectomy. The exception is some patients over the age of 70, we may not give radiation if they're small and the tumors are low grade and are estrogen receptor positive. But typically, radiation will be whole breast with a boost to the lumpectomy site. But we also have partial breast radiation, which takes many different forms. We have an excellent radiation oncology team, and there are many options that are really individualized for our patients. And then last is endocrine therapy. So this is not an endocrinological issue. This is not an abnormality in estrogen production or progesterone production, because a lot of times patients think that's the issue. It is not. But endocrine therapy refers to the opposite of hormone replacement. We are going to block estrogen from getting to the majority of breast cancer cells that are estrogen receptor positive. The two medications that we typically will use are going to be tamoxifen, that we can use in all age groups because we block it at the target, or aromatase inhibitors, which will then inhibit the conversion of androgens into estrogens. And this only works in postmenopausal patients because if your ovaries are functioning, whatever you're producing from the aromatase enzyme is going to be very little. There's 3 different types that we use, and we try to tailor that to the patient. This is our center, and this is the front of Miami Cancer Institute. We are located somewhere on that glass building on the 2nd floor. We have our own area, and we are more than happy to have you come and visit us. You can certainly get in touch with Dr. Hakim if you're a student and you want to come rotate with us. There are programs that are available, and we're always happy to have students. We have an affiliation with the Florida International University Medical School, so we will typically have medical students with us who rotate. I will have one coming in the next 2 weeks, and we have residents now. We just started this in August. We're very excited, and we just had our new residents starting to rotate us, our general surgery residents. So we're very excited about all of these possibilities. Yeah, that's it. We're excited to see you in Miami if you'd like to come.
Dr. Giron, what a wonderful presentation. To have a surgeon to put it in such an incredible context, it's absolutely phenomenal, especially for all the medical students. We have a huge cohort today. We have about 110 students that have logged in. and I'm very grateful that they've done so. You touched upon of the many components or categories of or the stuff that you have at your disposal for you to not only diagnose but also to obviously treat the condition and spare the life or increase the quality of life of that woman or in that percentage and the small percentage for men that
Right.
perhaps get diagnosed with breast cancer. The news is that in the past 10 years, if not 20, we have done a phenomenal job in public health in identifying proactively and trying to bring these individuals, this woman in their great majority, to the forefront in order for them to get diagnosed early so they do not have to come and visit a surgeon. They do not have to come and deal with a medical oncologist for the subsequent treatment. The good news is that we have tools at our disposal for us to actually be in the preventive stage to actually tackle these huge problem that we currently have globally. I wanted to just bring at least this to the forefront since they are students, the great majority that have joined us today. And from the public health standpoint, it has always been a conversation that needed to be had in order for everybody to be aware. And you did say at the beginning of your presentation that we have done a lot of great work in publicizing and making sure that the media is talking about it and get the stigma away in order for
Mhm.
women to take the initiative and stop being scared and go for it. And the reason being is because of the alarming number of cases that we are currently seeing globally. I was looking before your presentation, tried to get at least the latest numbers, and I was kind of taken aback, Dr. Giron. It was the burden of this particular disease is quite impressive. It's 462,000 individuals or women that get diagnosed with cancer, and 100,000 deaths are related to cancer. So this is quite a number. And for a surgeon of your stature to actually only focus on breast and consistently be busy day and night, diagnosing,
Mhm.
biopsying, taking women through surgery, trying to explain the different modalities, interacting with your interdisciplinary team, allocating the path for these women to understand that there is a way to improve their quality of life. It is quite challenged. From your standpoint, doctor, and one of the things that I wanted to actually touch upon is perhaps a phenomenon in that we have been seeing in the last years, which is the increase in the younger population, the diagnosis of breast cancer. In your opinion, what is it that you consider that this is related to? Why is this phenomenon occurring? And more so, and more importantly, in the Caribbean and Latin America is where we see this volume continue to increase.
Yeah, so it's, we don't have the answers necessarily for why we're seeing an uptick in the breast cancer diagnosis in younger patients. Not all of the younger patients are going to have genetic mutations. Um, we have in families that do have genetic mutations, sometimes we look at the actual presentation, the age at presentation. So if you have a family where the person that had breast cancer or the people that had breast cancer in their 20s, late 20s, which is not the usual, but early 30s, then we really want to be proactive with those families. We want to test those patients. So usually you want to test the index patient, so the one who had the cancer, and then you want to test the others, because if we do identify a mutation, then clearly with those patients, the most common mutations that we're going to see are BRCA1 and BRCA2. We can take proactive steps, right? We can look at prophylactic mastectomies, try to decrease that risk of breast cancer developing to begin with. We can also have them seen by the gynecologic oncologist or other colleagues that work with us, especially with the BRCA1 and 2 mutations, get those fallopian tubes and ovaries out as soon as you're done with child rearing. That doesn't tell us the reason why the younger patients are
Right.
getting it, but the treatment is very different. You're looking at very different factors. You don't want to make a 30-year-old patient postmenopausal with tamoxifen.
Right.
with chemotherapy, with endocrine therapy. So there are a lot of factors that we need to take into consideration when we're looking at the younger patient population. So with that in mind, we have a young breast cancer patient program where we try to streamline their care to
Mm,
get everything done as quickly as possible. And one of the aspects of that, obviously, is that some of our patients are nulliparous. They haven't had children and they want to
mhm,
have children. But now, instead of looking at, am I in a relationship already? Am I married? Do I have a serious relationship? And I can go ahead and start thinking of having a baby. Now I have a breast cancer diagnosis.
mm,
Now I'm going to be infertile. So getting that patient to the fertility preservation team as soon as possible becomes very important before we start treatment that can then render them infertile. So there are a lot of things that become very important for us to take into consideration that are different than in a patient who is at a later stage in life.
right. And that I guess we can dovetail into this particular question that Sasha has, which is if patient has a family history of breast cancer, should they ask for genetic testing?
Okay, so it depends on the family history, right? Sometimes we don't see these that much anymore because we have done a good job of increasing awareness in terms of our community. But if the patient comes in and they tell you, my grandmother had breast cancer at 95, 82. They're the only person with breast cancer. Well, typically those patients have breast cancer because they're older and they're common in older patients. But it depends on the type of history. So I touched upon that on the slide. So what are we looking at? We're looking at certain types of family presentations.
Mm,
Multiple family members, mother, daughter, sister, grandmother, aunts. Doesn't matter if it's paternal or maternal.
right.
Right, because a lot of times they'll come in with a very large paternal history, and everyone has told them it doesn't matter because it's on your father's side. These are not sex linked. So it doesn't matter mom or dad's side. And it's also not additive, right? So you can't take one from here and one from there and say, I have two, right? So it's really, you really are looking at large numbers of family members. We're looking at families where you have a combination of breast and ovarian cancer. You have males with male breast cancer. You
Mhm.
have prostate cancer. We also have pancreatic cancer. So pancreatic cancer can be seen with the BRCA mutations and with PALB2 mutations.
Mm,
So pancreatic cancer also becomes an important diagnosis for us to look at, and also melanoma can be associated. So for our patients that, for example, undergo genetic testing and they're positive, we then put them in a program where we're going to hook them up with a gastroenterologist.
mhm,
Typically, the starting point is going to be an MRCP, take a look
mhm,
at that pancreatic system because we can't do anything prophylactically. We're not going to do a pancreatectomy to prevent
right.
pancreatic cancer, but we want to screen and monitor so that if something does come up, it's smaller and perhaps curable.
Yeah.
We get them to see the dermatologist, do skin checks. And obviously, we will talk to them about screening and potential surgery. So not everybody should have genetic testing because of a family history, but if the family history falls into those categories, then yes, that patient would qualify.
Right. And at times when we see this history in our families where women are obviously at risk or have already suffered from breast cancer that had undergone mastectomy, there is this immediate jump from the young generation that, I want my breasts removed. How do you feel in regards to the Angelina old topic? How do you feel about that particular phenomenon? Has that quiet down, or do we still see women requesting their breasts to be
Right. We
removed?
we do. We do, actually it's amusing that you should say that to me because we very recently had a patient with benign findings, and the patient and family were wondering if they could do what Angelina Jolie did. And we're like, you don't want to have to do what Angelina Jolie did because Angelina Jolie's family does have a BRCA mutation with very high penetrance. Basically, all the women in her family have died of either ovarian or breast cancer.
Right.
So clearly, in her case, it made perfect sense to proceed with bilateral prophylactic surgeries, both for her breast and then also the risk reducing surgery with the gynecologic oncologist. So if there is a mutation, we want to look at the type of mutation. We want to look at the particular family history. And then if it's appropriate, this is something that we do recommend and we do encourage. We try not to look at, or the guidelines in terms of genetic testing are going to be that you don't test anyone until they're 25 years old. This
Mhm.
is not a disease of young people. So you're not going to have a 13-year-old with breast cancer. So we don't test children. children. 25 seems to be the age where most people have already reached some point in their life where they're kind of know where they're going and they're able to have enough maturity to take that information and then make decisions that make sense. And it really depends on the patient. It really depends on where they're at, what they're thinking, how they feel, what their life experience has been.
Gotcha. Perhaps this following question might be somewhat of an abstract, but oftentimes we have requests from women that would like to have a breast reduction. They have nothing. Their mammograms have been absolutely normal throughout their stages of screening, and all of a sudden they want a breast reduction. Is there something that should be explained to the woman that is going to undergo a breast reduction, or the plastic surgeon, do they take an initiative to actually document or review the tissue after the mastectomy? How does that work?
The
In
patients
regards
want to,
to, let me just to clarify, I'm sorry, Dr. Giron.
yeah,
So just in case, if in the future there is a potential breast malignancy or something in the remaining tissue after the mastectomy, after the breast
reduction.
reduction, how
Mhm.
do we know that is there how do I frame this? Would it be detrimental to just do the breast reduction without a pathological study together with the
Right.
breast reduction, or does that not necessarily matter?
Well, so, in terms of a breast reduction, obviously we want to look at certain factors. So what are we looking at? We're looking at a patient who's coming in, they have significant neck or back pain, they have grooving.
Sure.
So you could literally put a pencil where their
Yes.
bra shoulder strap fits. They have a large breast size, right? So you want a larger cup size, a lot of ptosis, and then a lot of times in that inframammary fold, it will have constant yeast infection. So that intertrigo with skin breakdown and pain. So if they meet those criteria, they can indeed have a breast reduction and will benefit from a breast reduction. However, we want to follow standard guidelines. So if the patient's coming in and they're younger, they're, 28 and they've been around enough with their breast that they know this is something that's really causing problems for them, they can have a breast reduction and there's really no guideline that says they need to be screened. But if the patient is coming in and they're 40, they're 42, they're already at an age where we should be doing screening. So in that case, the reconstructive surgeon, the plastic surgeon, will require, if they're practicing as appropriate, will require that they have their screening studies, that they do have their mammogram, if indicated, ultrasound, if indicated, MRI, and that everything is good, there aren't any findings, and then they can proceed with the breast reduction. The breast reduction doesn't necessarily decrease your risk of developing breast cancer. It certainly doesn't increase your risk of developing breast cancer. You will have a different look, right? So now the pathologist is going to have to start, the radiologist rather, will start a new baseline. So you'll have your mammogram, and then sometimes they want another 6 months because now your breast tissue looks different. It's
Hmm.
smaller, there's scar tissue, so they want to establish a new baseline in terms of what the appearance is. But we wouldn't say to someone, don't have a breast reduction because of a risk of breast cancer. In terms of doing mastectomies in the future, it can sometimes be a hindrance to doing nipple sparing or to
Sure.
healing, but we are a very busy service here. We're used to dealing with patients who've had everything, who've had previous lumpectomies and radiation, who've had breast reductions, who've had burns to their breast. We can work together as a
Well,
team to take care of virtually anybody, but breast reductions definitely will increase your quality of life, but the patients have to know that they are going to trade big breast size for scars. This
for
is not
scars.
done without scars. Okay.
That's
And
right.
that triple point, that little point where you got this side, this side, this side, and that side coming together. So that triple point will very often have problems healing, and you may get a little bit of hypertrophy in the scars. So sometimes they come back and they, we don't do that surgery here. We have the reconstructive and the plastic surgeons do it, but they'll come, look what happened to me. Look at this. And we're like, yeah, that's pretty
Mhm.
normal. But you feel better. Your back feels better. So you are trading large breast size for scars.
For the quality of life as well. Yes.
Exactly.
There is a question that was posted by Andula, and it says, so for a typical doctor hyperplasia, do we need to operate?
Okay, so atypical ductal hyperplasia for us, our standard of care within our guidelines, right? American Society of Breast Surgeons, SSO, ASCO. Atypical ductal hyperplasia does require surgical excision because up to 20% of the time we may upgrade to ductal carcinoma in situ or to cancer. Atypical lobular hyperplasia, the upgrade is much lower, so we do not operate on ALH, but ADH we do operate on. There may be some exceptions. There may be like a tiny focus, or there are some places where under studies where they will follow patients with ADH or follow patients with DCIS of low grade and not operate. But most of our patients here are not willing to wait and see. They don't want to see what happens in 6 months to a year. Is this now worse than it was? Some types of patients will do that, but that really should only be done within a study. So our recommendations for our patients, you have atypical ductal hyperplasia, we are going to excise.
That's wonderful. You did mention that October is Breast Awareness Month. We're all up in arms with the amount of requests for mammograms, and we are so thrilled that there are so many women coming forward and saying, I want my mammogram. In one way that public health can actually help in making sure that the number of cases tend to get to be reduced in the future, which it doesn't seem to be the case because of the statistics, since we're projecting a huge, huge increase if we continue in this path. But the idea is to prevent it. Obviously, you did mention signs and symptoms that the woman can experience, and to bring it forward to their physician, it's extremely important. Bringing down the price of mammograms is one incredible way that many of the health systems around the United States and, of course, in many other countries have used as a way of enticing and bringing women or those mobile units to go to the rural areas for them to have their mammograms. And just to recapitulate, you did mention that between the ages of 40 and 44, the mammogram screening is the way to go. And then 45 to 54 should be getting a mammogram every year. And then 55 and older, it's every other year. So
yeah, those are the American Cancer
the
Society
American Cancer
recommendations. So I try
Society,
to follow regulation here, but we say over the age of 40. We're
over
going to do
the age
yearly
of 40.
because we
Exactly.
have the resources. Definitely we understand that in some areas there may not be resources. In other countries, the guidelines may be different.
Yeah.
For us, we do see that yearly mammogram does make a difference for us. So for us, that's going to be our recommendation. Age 40, yearly mammogram.
Yeah.
And
And for
then
all
we'll
the
add adjuncts depending.
Exactly. And for all the gentlemen that are actually in our call today, please help us out, entice or help our sisters, moms, and aunts, and every woman that we see to actually get their mammogram, because that is extremely, extremely important. And one incredible tool that all the good doctors at MCI remind us that one of the easy ways of actually doing it is by using our hands in the shower and learn to explore our chests and breasts, of course. So there is so much work that you've done, Dr. Giron, and so much more to come. So I want to thank you because I know how busy you are and you are, and for you to take this time and give us a space to share your knowledge. It's a privilege for us. So thank you so very much for your
I
participation.
appreciate that. And I appreciate everybody who joined us. And I want to tell you two take-home messages. How do we make things better? Number one, by becoming good physicians. All right. So you're a medical student. You have chosen this path. Take it full on. Learn. No one can learn for you. You must learn. If you don't learn and form a good foundation, you will not be a good doctor. We don't need bad doctors. We need good doctors. So make sure you study very hard and that you are able to recognize what is and what isn't a breast cancer so that you're not part of a delay in diagnosis. And then the next thing is to impart on your patients, to impart on the people in your family, simple word, simple phrase, do not be afraid. Patients don't
Mhm.
go and have their studies done because they are afraid. Knowledge is power. If it's negative, great. If it isn't, we may find things when we still can do something. But if
That's right.
you ignore and you are afraid, we may not be able to help you. And we don't want to see that.
That's beautiful, Dr. Giron. Thank you so very much. And on behalf of our entire team at Baptist Health International, thank you once again for this amazing presentation. And to all of you for participating and for listening today. If you have additional questions or you would like any other details, and or if you have someone that you would like to refer to Dr. Giron or to Miami Cancer Institute, please let us know. Send us a note at bhiwebinars@baptisthealth.com. If .net, I'm sorry, BHIWebinars@baptisthealth.net. If it is a clinical question, we will be more than happy to send it to Dr. Giron, and we will respond back to you on time. We look forward to seeing you all in our next medical lecture series, which is scheduled for November 12th, 2025. Thank you once again, and have a wonderful afternoon. Dr. Giron, have a wonderful and pleasant evening.
Thank you, everybody. Thank you so much for joining.
Bye. Thank you.
Bye-bye.